right, here we are, Fernando and Alison. We are online. Okay, without further ado, please, Fernando, introduce Alison and let's go. Thank you.
Okay, it's a great pleasure for me introducing Alison. I will go quickly through her bio because we're running out of time. So I think that reading her bio will help you to understand how she achieves so fascinating research. Alison Marsden is a professor in the Department of Pediatrics, Bioengineering, and by courtesy Mechanical Engineering at Stanford University. She's a member of the Institute of Mathematical and Computational Engineering from 2007 to 2015. She was a faculty member in Mechanical and Aerospace Engineering at UCSD. She graduated with a BSc degree in Mechanical Engineering from Princeton University in 1998 and a PhD in Mechanical Engineering from Stanford in 2005. She was a postdoctoral fellow at Stanford University in Bioengineering from 2005 to 2007. She was a recipient of a Burroughs Wellcome Funding Career Award and a Scientific Interface in 2007 and an SFF Career Award in 2011. She was elected Fellow of IMMB and CIAM in 2018 and APS TFD in 2020. Her research focused on the development of numerical methods for cardiovascular blood flow simulation and application of engineering tools to impact patient care in cardiovascular surgery and congenital heart disease. Please, Alison, the floor is yours.
Thank you so much, Fernando. I'm going to share my screen. All right, so I'm going to talk to you about work going on in my lab at Stanford involving patient-specific modeling for virtual treatment planning in cardiovascular disease. And my goal today is really to talk to you about how we apply finite element models of blood flow to try to impact, have real impact on clinical problems in cardiovascular disease. And I'm going to show you one example from a pediatric case and another example from an adult case. And then we'll talk a little bit about some of our methods. So in general, my lab works on a range of problems in both methods development and in applications of cardiovascular disease. And on the methods side, we work on fluid structure interaction and uncertainty quantification, numerical methods for trying to accelerate simulations and also optimization of medical devices. And we try to apply all of these tools to cardiovascular disease applications. This can range from congenital heart disease in pediatric patients to adults with coronary artery disease. And, I think coming from a traditional engineering background, we may be very used to looking at problems with, say, complex flows or high Reynolds number, turbulence. And what we're trying to do is take a lot of the numerical methodology and approaches that have been developed over the years in more traditional engineering applications and now move these into the realm of the medical domain. So many of the fundamental numerical methods approaches will directly transfer over. Generally, our Reynolds numbers are in the cardiovascular system are lower than many industrial applications, and our flows tend to be either unsteady or transitionally turbulent, but usually not fully turbulent. So this may seem like, well, these problems are sort of easy. But what I want to try to get across is that there are different and unique complexities arising in the biological space and physiological space that don't necessarily arise in these other types of engineering problems. So one issue is that the cardiovascular system is comprised of billions of blood vessels, many of which we can't actually see in the images that we take, like a CT or MRI scan. We have very complex geometries, often with deforming vascular structures. And actually, these tissues that we're simulating are alive and they respond to their environment. So we have to deal with the fact that these tissues can remodel in response to mechanical forces. They also can contract. So the heart is a multiphysics problem with, an electrical system and activation of cardiomyocytes that cause contraction. There's cell signaling, there's autoregulatory mechanisms coming from physiology. All of this is in the context of both health and disease, with a variety of different disease applications that can vary what quantities we're interested in. And then, of course, given all of what I just told you, there's enormous uncertainty in sort of the data that we typically assimilate into our models. And so we'll touch on that a little bit at the end of the talk. So our goal with developing a lot of these patient-specific modeling tools is, usually we're constructing a model of a specific patient from image data. And what we want to use that model for is some sort of treatment planning or to improve understanding of disease progression. These are just a couple of typical examples. So the one on the top is a case where we're using a model to plan a coronary artery bypass graft procedure. We're going to talk a little bit more about this later in the talk, but you can see that the models give us a very controlled way of varying things like a bypass graft geometry that is shown in red, while keeping everything else in the model fixed. And this is something that we can't do in such a controlled way, of course, in live patients. The one on the bottom is a pediatric application where we're comparing two different surgical methods for patients with single ventricle congenital heart disease. Typically, the kind of solvers that we use for this are finite element SUPG type solvers with linear tetrahedral elements. We also are using VMS methods. We're typically using second order time advancement, like a generalized alpha scheme. We have a couple of different ways of approaching fluid structure interaction. This is usually either with a less expensive coupled momentum method or with fully coupled ALE, where we can include a wall thickness in our simulation. We've also done a lot of work on developing specialized linear solvers. A lot of these problems are coupled, for example, at the boundary conditions. So you can see here in the middle, a 3D model coupled to a reduced order model of the rest of the cardiovascular physiology. This leads to often to ill conditioning problems that requires special treatment of the linear solver and preconditioning. So I'm not going to go into too much detail, but I want you to take away that there's a lot of rich problems to work on in the cardiovascular space in terms of finite element methodology, because of the fact that we have complex geometries with deformable walls that are often anisotropic nonlinear tissues that are also incompressible. We have coupled problems where we're coupling a 3D model to reduced order models, and then this leads to interesting work in the space of linear solvers. So I want to tell you about two different applications, and we'll get into a little bit of methods as we go along here. But the first one is a problem where we're looking at pediatric pulmonary stenosis. So patients born with, in particular, two types of congenital heart defects. These are children born with Williams syndrome or Alagille syndrome. And there's some details here about, what genetics leads to these types of conditions. They're relatively rare, but both of these conditions lead to severe abnormalities in the pulmonary arteries, and in particular, extensive narrowing of the pulmonary vessels, which is called peripheral pulmonary stenosis. And you can see on some of the images here, these narrowed sections of the pulmonary arteries that should not be there. And so the clinicians are struggling with, how do we treat these patients? This can lead to serious consequences like pulmonary hypertension, unequal flow to the right and left lungs, and eventually heart failure, right ventricular failure in particular. So current treatment options for these patients are either to do an extensive and complicated surgery. These surgeries are complex. They are generally quite successful, but there are very few centers where this can be done. They take many, many hours to basically reconstruct the pulmonary arteries, patching, and so the other option is to do stent placement, which is where you go in with a catheter and you inflate a stent to try to open up the pulmonary arteries. However, outcomes after this are generally very poor. These procedures are often ineffective in changing the pressures in the right ventricle, and there are really high rates of in-stent restenosis, or basically the stent is placed and then the narrowing occurs again. And so our question is really, should they be doing the stenting, and why is it that it's not effective? And so we, in this project, aimed to use a model to try to answer this question. So this is our patient-specific modeling pipeline. We generally start from a set of image data. So you can see here in step 1, we have a CT scan of this patient. We then generate vessel centerline paths and segmentations to build a personalized anatomic model that you see in step 3, where we can mesh that model using an unstructured mesh. We then apply boundary conditions, which I'll show you in a minute, and then run a finite element Navier-Stokes simulation. And we do this whole modeling pipeline with an open source software that we develop in my lab called Microvascular. So the boundary conditions that we're using in this case are we're hooking up the inlet to a lump parameter model of the right side of the heart. These are basically circuit models that we connect. We numerically couple these to the inlets and outlets of our pulmonary model. And the outlets are connected to RCRCR circuits that are shown there. For tuning the boundary conditions, we replace the 3D model with a surrogate lump parameter model that includes nonlinear resistors that have been tuned to match the pressure flow behavior of the 3D model. And this allows us to tune the boundary conditions very quickly for a given patient, and then put back in the 3D model that we can verify matches the clinical data for that patient. We're also including, because the vascular system will actually adapt dynamically to changes like insertion of a stent, we're including a microvascular adaptation model to predict the pre to post stenting behavior of the distal vascular tree. And this is a model that we adopted from Princeton and COPPE. This includes terms for wall shear stress, pressure, metabolic stimulus, conduction of the stimulus up the vessel, and a shrinking tendency. And so we've reparameterized this for our purposes. So what we did in this study was we started with 4 patients with Alagille syndrome and 2 patients with Williams syndrome. And you can see here in the pink that we're able to insert, so in the model, virtually insert these stents. And then our goal is to make a prediction of the post-stenting conditions. And we've done in these patients both 2 levels of stenting. So many clinical centers will stent only the proximal or closest vessels, and some centers will stent extensively both the proximal and the distal, meaning everything they can reach with the catheter. And so we did both of these scenarios in our models. You can see here with the proximal and extensive stenting. So then what the model allows us to do is to predict what would happen to the cardiac output. So how much blood is the heart pumping, and the right-left flow split to the pulmonary arteries. both with the, moving from the pre-stenting procedure to the post-stenting with these two scenarios of proximal and distal. We also evaluated the effect of this adaptation model, which turned out to be relatively minimal. And you can see in the results here that in some patients, the stenting was effective in equalizing the right-left flow split. So the orange and blue are the right to left flow split in those bars. So we want to get an even flow split, and that is happening in some patients, but in some patients, it's actually, the stenting is actually making it worse. And we're not really effectively not getting big changes in the cardiac output. We also looked at pressures, and what you can see here, the main takeaway is that we're not really effectively reducing the pressures with stenting. So we would like to get the pressures down to, say, 10 or 20 millimeters of mercury. But the stenting, especially the proximal stenting, is not effective at all in reducing the pressures. And extensive stenting has effect in some patients, but overall is still not having the effect that we would desire. The reason for this has to do with quantification of the resistance of the pulmonary arteries to everything that's downstream in the vascular tree. And the resistance of this distal vascular tree is really much, much higher than the resistance caused by these narrowings, even extensive narrowings. And so we were able to quantify for the clinicians what is the fraction of this resistance that's occurring in the pulmonary geometry that we can see versus what's downstream, which is dominating the flow splits. And this is just a view of the simulations in the post-intervention cases, so both pre and post with these two scenarios. And then what we were able to do for the clinicians is make maps of, where would be the hotspots of resistance that you should target using these stenting procedures. So you can see the red colors here are where the resistance contribution from the geometry is highest. And so we would be able to help them target what would be the most effective areas to stent given the geometry of a particular patient. We were also able to damp some unphysical oscillations that we were getting from our FSI simulations by using external tissue support. So you can see in the top, we're getting these oscillations in our pressure and flow curves and this is using a coupled momentum method, adding just a little bit of damping to account for the tissue that's surrounding these vessels, which we know is there, reduces these oscillations without affecting the bulk flow and pressure predictions from our model. So it's important to account for these types of things in our modeling to keep the results physical. Okay, the second example that I want to show you has to do with adult coronary artery bypass graft surgery. And this is one of a number of surgeries that involve insertion of some sort of artificial bypass conduit. This happens in the peripheral vasculature, it happens in pediatric heart surgery, and it happens most commonly in coronary artery disease. And when we put in a type of conduit, it can often be synthetic, but sometimes it's a native vessel that we harvest. So in the case of coronary artery bypass surgery, the vessel is harvested out of the lower leg and then it's inserted into your coronary circulation, which is the vessels that are supplying blood to your heart. And so what happens is that these vessels are living and they also respond to their environment. This surgery is the gold standard for patients with multi-vessel diffuse coronary artery disease. And of course, coronary artery disease is the leading cause of death in the US, about 1 in 4 deaths. This is a very common surgery, about 350,000 patients per year in the US. But what is the problem here? The problem is that for the vast majority of these procedures, they need to insert a saphenous vein graft. And this type of vein graft is harvested out of your leg. It's used to being in the venous circulation, very low flow, low pressure. It's removed from that environment and implanted as a coronary bypass graft. These grafts actually fail at alarmingly high rates. About 50% of them will fail within 5 to 10 years of the surgery. And part of this has to do with biomechanics. So this vein is sitting in your leg under very low pressure, low flow conditions, and it's suddenly inserted in the coronary circulation where it experiences a step change in mechanical conditions, whereby the pressure is increased about 20-fold and the flow is increased about 4 times. And this sets off a complex remodeling process whereby this vein is, it's alive, bonding to its mechanical environment, and it then tries to become an artery, essentially, which is a process called arterialization. So we wanted to understand this process with modeling, and we started off doing this by just asking the question, what is the mechanical environment that these veins are experiencing? So we did, first of all, a modeling study with 5 patients who have undergone this procedure. We built these models from CT. We did automated tuning of the boundary conditions to using optimization under uncertainty to match the clinical data for each patient. And then we did FSI simulations of the blood flow with appropriate material parameters for the different vessels of interest. And this is from biaxial testing data that's in the literature. So from these 5 patients, we extracted the venous grafts and the arterial grafts separately so that we could try to compare them. The arterial grafts in these patients tend to perform very well, whereas the venous grafts tend to perform very badly with high failure rates. And so we wanted to compare what is the mechanical condition that these grafts are experiencing. And we did find significant differences. There were differences in wall shear stress, in atheroprone area, so the area of the graft that experiences low shear stress, and also differences in wall strain. So then based on that, we wanted to then ask the question whether we could address this problem of the step change in loading by providing a more gradual change in the mechanical loading that these grafts are experiencing. And then would that lead to a more favorable remodeling process that could avoid some of the graft failure that we see in the clinic? And so we decided to use a different type of model to try to answer this question, which is a vascular growth and remodeling model. This model uses a constrained mixture approach. And we collaborated with Jay Humphrey to implement this model for venous grafts. So what this type of model consists of is a mixture of the constituents that make up the vessel wall. So this is collagen, elastin, smooth muscle cell. And then one is able to make a mechanical perturbation to flow or pressure and predict the change in radius, thickness, and composition of the vessel wall that results from this. And so we wanted to then use this model to ask, what is the biomechanical response to altered hemodynamics in a vein graft? And we could use that then to compare a vein experiencing this step change in loading to a vein that's experiencing a more gradual change in loading. So this is what this type of model looks like. It contains a set of equilibrium equations for circumferential and axial directions. It contains a set of constitutive equations for these different components in the wall, elastin, smooth muscle cell, and collagen. They each have their own mechanical properties. They have fiber directions. They're anisotropic. It contains also a mass addition and removal terms, which are connected to the shear stress and the circumferential stress, which comes from the pressurization of the vessel. So these are the delta sigma and delta tau terms. And then it contains a set of evolution equations for mass and stored energy. And so we used optimization methods to reparameterize this model for the setting of a vein, which had not been done previously. And then we were able to apply it to study this question of gradual versus step change in loading. And so you can see the red X's in the plots on the top represent cases where the vein graft has failed under high changes in flow and pressure. That represents the transfer from the venous circulation to the coronary circulation. And so we were able to show with the model that moving from a step change in loading to a gradual change in loading of either flow or pressure over 3 days would decrease the failure of the graft, and that gradual loading over 8 days would completely eliminate this failure, even out to 300 to 500 days. So what this means is that gradual loading over the first 8 days after surgery will affect the long-term remodeling behavior at 300 to 500 days. And so this is very desirable because if we could find a way to implement this gradual loading, even for a short time after surgery, we can have a very potentially positive effect on the ultimate behavior. My student Abhay, working with Jay, also implemented a model with external mechanical support of the vessel. So as a way to implement this, we looked at using an external mechanical scaffold to relieve the pressure, basically the pressurization causing circumferential strain. And so he found that this would be an effective way to achieve this in practice. We found that offloading the vessel could reduce the compensatory mechanisms that increase the wall thickness, leading to failure. And he also included inflammation in the model. And we found that there's a sweet spot with inflammation where if you provide this external support for too long, it can actually cause chronic inflammation. Too short may not have the desired effect. So there's some sweet spot in the middle there. So we then actually tried this concept in a sheep study. So we took 8 sheep. We did a swap of their jugular vein with their carotid artery. So this allows us to study how the jugular vein would respond to an environment with increased pressure. In half of the patients, we just did the swap with nothing else done. And in the other half, we wrapped the vessel the outside of the vessel with an Ethicon mesh that would degrade over time. You can see in the top, so I'm showing you sections of the vessel from these sheep surgeries after 4 months. So we harvested the vessels after 4 months of time. You can see the control vessels are on the top. These were the ones that had no mechanical support. And the ones that were supported externally with this wrap are shown on the bottom. So what you can see is that there's obviously a huge difference in these samples. The ones that were not wrapped have highly variable outcomes. One of them stenosed completely, so closed off. One of them formed a large aneurysm. Whereas the ones that were wrapped tend to be much more uniform and in some ways predictable in their outcome. And I'm not going to go through all of these in detail, but we did find that our model correctly predicted an increased stiffness in the wrapped vessels compared to the unwrapped. We also found statistically significant differences in thickness, where the wrapped vessels were less thick than the unwrapped vessels. And we found trends in diameter and in vivo stretch. We also looked at these vessels in histology. So this is where you can look at, what are the actual contents of this tissue. And we found significant differences in collagen deposition in the wrapped vessels and then trends in some other quantities of interest as well. And you can see that the wrapped vessels on the bottom have a much more uniform kind of appearance in the histology. And then we actually did RNA sequencing to look at gene expression in these vessels. And what I'm trying to get across here is that this, starting with this kind of basic mechanics model led us in an interdisciplinary collaboration to reveal quite a bit of more understanding of what's actually going on in the mechanobiology. And then the mechanics were really important for triggering different responses in this living tissue that makes up the vessel wall. We found very large differences in RNA sequencing, meaning that this difference in mechanics between the unwrapped and the wrapped vessels is triggering a difference at the genetic level in terms of what pathways are signaled and turned on. And this can lead to hopefully improved basic understanding of what's going on in this process. We're also now working on a three-dimensional model of this growth and remodeling process. So the growth and remodeling model that I showed you is essentially a single slice of a vessel where you predict a change in radius or composition. What we would like to do next is move towards fully three-dimensional models where we can predict the spatial changes and things like stenosis formation in 3 dimensions. We can do this by coupling our FSI simulations to 3D representations of the growth and remodeling. And we have started to do this already and found that one of these models was able to predict stenosis formation in a tissue-engineered vascular graft in another study with Chris Brewer at Nationwide Children's Hospital. And that this matched the observations that they're seeing in their sheep studies where they're implanting these grafts. You can see the formation of the stenosis at about 30 days and its resolution, spontaneous resolution at about 180 days. And then the same trends observed in the sheep models that are below in this slide. I'll just say a couple words. I think we're just about out of time, but uncertainty quantification is hugely important in these problems because we deal with very often very messy clinical data. So what you're seeing here on the left is a real catheter pressure signal that was left in one artery of one patient for many, many heartbeats. And it's quite noisy. And so we need ways to do both parameter estimation, where we're assimilating this type of data into our models, and then uncertainty propagation from these type of models to the predictions that we're trying to make. And we have done this in particular working with Daniele Schivazzi at Notre Dame, who was formerly a postdoc in my lab. We've developed an automated parameter tuning method under uncertainty using a Metropolis Hastings method. We can then generate distributions on the parameters of our models. So this might be things like material properties or resistance or capacitance values in our lump parameter boundary conditions. And then we can sample from these distributions to generate confidence intervals on the outputs. We've done this so using a Calhoun and Love expansion to model the time-varying uncertainty in a coronary artery pressure perturbation. So this is just one example where we've modeled the inlet uncertainty of the pressure. And then we propagate this to quantities of interest. And that allows us to put a confidence envelope on our simulation predictions. One method that has been particularly useful in accelerating this process of UQ has been multi-level, multi-fidelity approaches. And so here we're able to take advantage of the hierarchy of models that we have sort of readily available for the cardiovascular system. So we have 3D finite element models, as well as 1D wave propagation models and 0D circuit models. these models are actually quite well correlated for our problems. And so we're able to run essentially thousands of 0D and 1D simulations nearly for free. We put these together into a multi-level, multi-fidelity workflow. We use the Dakota package to do this, working with folks at Sandia. And we're able to get orders of magnitude speed up in our uncertainty quantification by leveraging these models. So what you're seeing in the chart here is effective cost of basically 3D, the effective number of 3D simulations that you would have to run using multi-level approaches compared to traditional Monte Carlo, which is orders of magnitude less when leveraging these very cheap, very fast models. So multi-fidelity methods could save us orders of magnitude of computational cost. And so we have implemented these, and we're also working on some additional types of reduced order modeling going forward. Just a couple of other projects. We're working on optimization of some medical devices, such as pediatric heart pumps, as well as multi-physics modeling of the heart, which includes electrical and mechanical activation, as well as flow inside of the ventricles. We run an open source project called Microvascular, which is on GitHub and provides this whole pipeline from image data to simulation results. And we also have a large repository of models, images, models, and simulation results that are available, publicly available. And these are all compatible with Microvascular. We're working on various ways of leveraging this for machine learning applications in my lab. So I'll just put up the summary here, and I'm very happy to take any questions that you might have.
Hi, Alison, fantastic work. Let me go to the chat for a question from America Barbosa. Alison, excellent talk. We see already a kind of patient digital twin in some clinical treatments like orthodontics. How far are we from this paradigm become a standard clinical tool for treatment surgery planning?
Yeah, so there is one company that's providing a clinical service, and that's HeartFlow, that was founded by Charlie Taylor. They are doing a test called FFRCT. And the way that they do that is the hospital sends the CT scan to the company. They do a finite element simulation, predict an FFR value, and they send it back. I think there are a couple of barriers right now to widespread clinical adoption of these tools in general. One is that we need to get much better at the anatomic model construction and automating that, likely with machine learning. And then we need to get better at the sort of reduced order modeling side, or real-time simulations that could provide clinicians with more immediate feedback. Right now, this workflow requires quite a bit of expertise and user intervention. And so I think working on ways to automate this pipeline and put it in the hands of clinicians is going to increase adoption.
Let me come with one question for my own. Regarding the UQ study, how hard is to convince a doctor that you have some error bars, and how he takes this in terms of having some support from you?
So we actually find that clinicians they actually live in a world of uncertainty already. And they're very used to dealing with statistics because they have to make decisions all the time based on incomplete and imperfect information, and they know this. And so part of our goal of doing the UQ is actually to increase their confidence in what we're telling them, because we're able to say, okay, we already know we have these uncertainties. They know they have these uncertainties already, so this is not a surprise to them. But we can now tell you, in a quantitative way, what is the range of values that we could be producing. And so I've actually been a little bit surprised at the relatively high comfort level that they have with the uncertainties.
Are you still there? I'm not sure. Yep. So, okay, now you're back for me. I mean, I can see you right now. So we don't have more questions from the chat. So I would like to thank you again for this great presentation. I'm not sure, Alvaro, is that you?
Yes, I am here.
Okay.
And I do,
So
do have a question.
Okay, I'm sorry. You have to use the chat.
All right, Alison, you said you use basically tetrahedral mesh, TET4 meshes. Do you think isochromatic analysis could improve your analysis pipeline?
Yes. Yeah, we are looking at some of those methods. We haven't tried them yet, although I've been involved in some collaborations involving those methods, isogeometric methods. One area where I think they could make a big difference in cardiovascular models is by allowing us to more easily manipulate the geometry and then have a pipeline for simulation, because we're interested in optimization and surgical planning. So having a NURBS type representation of the surface that you could manipulate and then simulate in a seamless way, I think is attractive. So yeah, we haven't gotten all the way there yet, but we're interested in exploring that.
All right. Fernando, please.
So I want to thank you again, Alison, for this fantastic talk. And now we have a couple of minutes before the mini symposium. Is that right?
Yeah. Well, yes. Alison, thanks a lot for being with us today here. It was a fantastic talk. Fernando, thanks for sharing the session. And well, I mean, we have the mini symposium sessions, and by 6:30, we're gonna have our caipirinha experience. Alison, you're welcome to. Okay, we're gonna have someone doing a caipirinha drink live from the studio to us all. Thank you. You're most welcome. Okay, thank you so much.
Thank you so much. Well, nice to see you all.
Yeah, well, maybe next time live, in person.
Yes.
Okay, live we are. All right.
Hope
Thank you so much. Bye-bye.
Bye-bye.